Thank you. So I'll briefly define the different types of pain and epidemiology, pathophysiology, and go to management. So acute pain, essentially, Professor has already described for us, is damage to the pathways, which is usually a short, brief period, very, very painful. That's essentially acute pain. Chronic pain, on the other hand, is pain that you've had for a much longer time, usually 3 to 6 months, and is usually a dull, aching pain, which is persistent, and not only is sharply painful, but also affects more spheres than just the physical, but the psychological and the social aspects of your life. So how much chronic pain do we have in Uganda? It's quite prevalent. Dr. Mwesiga found that 21% of patients who had HIV had chronic pain, and most of it was non-neuropathic. And also they found that in sicklers, 64.3% had pain, and this is it's children with cerebral palsy, and they had lots of other comorbidities around the pain. So it's not just the physical aspect of the pain, but the different comorbidities which may affect the social and psychological aspects that contribute to the pain. So the common types of chronic pain, usually with very uncertain etiology, people who have back pain, people who have chronic headaches. Musculoskeletal was a huge problem for one of the studies we did. Chronic pelvic pain, temporomandibular area, fibromyalgia. So it's not very specific in most cases. We did a study in refugees and found that almost the biggest problem of chronic illness is actually musculoskeletal pain. So pain is actually a huge reason for patients to present to the hospital. So the pathophysiology of chronic pain, pain begins with, you have stimuli, something maybe hurts you, causes damage to a peripheral area. Pain then moves on to the, so then it's transmitted from the peripheral nerves up through the dorsal ganglia to the pain, and then you actually perceive that now you have pain. Now what happens in chronic pain is that it's... Which one is the custom? So you have damage here, which then moves along the nerve root, goes up via the dorsal nerves, goes up to the brain, and then you perceive that as pain. So what happens in chronic pain is you have persistent stimulation, which goes on and on and on, and eventually you have remodeling of the nerves. And this remodeling of the nerves means that you're not able to inhibit stimuli, so that even if you don't have the pain, the physical damage to the peripheral nerves or to the cells, even if you don't have that physical damage, you still have chronic stimulation of the nerves. That's why eventually you'll find that nerve agents are the more effective organ agents as you go along. So what happens is you have poorly controlled acute pain, and this is what happens with most of the sicklers. So really poorly controlled acute pain results into peripheral sensitization, and then eventually you get what we call primary hyperesthesia, which eventually is hyperalgesia, which eventually is you have pain which is beyond the stimuli that you're exposed to. So then patients will then get prolonged discomfort, and when this peripheral sensitization continues, you eventually develop central sensitization, which is called central hyperalgesia, and then you get remodeling of the nerves, which eventually is the reason why things like paracetamol and NSAIDs may not be as effective. So eventually what you then end up with is chronic pain. So you then have poor response to analgesia, you have increased risk for physical dependence, patients who use more and more opioids, eventually resulting in abuse and addiction. And then what she mentioned was the paradoxical pain when you do take an opioid. So ideally when you take an opioid you should have relief of pain, but because of hyperstimulation of the nerves, you end up getting what we call opioid-induced hyperalgesia. So due to central sensitization. So when we are assessing patients who have chronic pain, because it's not just the acute chronic pain, we have to do a holistic assessment. So it's not just the physical, which the patient has, but also look into the social, the psychological, so that you're able to combine, what do I call it? A multidisciplinary model of looking after the patient, not just the physical or the biological agents that we're going to use, but social interventions as well as psychological interventions. So this is a better depiction of it all. So you may have a tissue damage, like in sicklers. So you have, say, a vaso-occlusive crisis, which will cause tissue damage. But because it is on and on and on, it's not very well controlled pain, it's acute pain, it then progresses on 3 months, 6 months, 7 months, you have the pain. Eventually you end up with the sensitizations that we've talked about, you end up with nerve remodeling, but it's not just affecting you physically, but also the social things around you. So you have emotional effects or psychological effect. You're thinking all the time of all your pain and all your problems, and then the stressors that come in. So eventually, it's not just the physical things that you have to do to control the pain. You have to go beyond that. So that's why management includes things like cognitive behavior therapies, things like encouraging people to do exercise to take their mind off the pain, encouraging people to have a social life and connectedness. Because if you're talking to somebody else, maybe you have a different conversation. Maybe you talk about, I don't know, the new latest movies or something that will take your mind off of your pain, and therefore you'll be able to help in controlling your pain. And then eventually we'll go to the pharmacological things like antidepressants and gabapentin. So management, of course, assess the current medication that the patient is taking. For example, in this patient, they are taking tramadol, they are taking pethidine, they are taking NSAIDs. So assess all of their medications and then review and decide which ones you need to take off, which one they need to continue. Some need to be discontinued, but if your patient is on oral morphine 5 milligrams, you need to taper it down slowly, because if you remove it suddenly, you cause withdrawal problems. So usually we say taper it by at least 50% every time you reduce the dose. Encourage physical activity, we talked about that. Nutrition is very healthy, very helpful, and getting plenty of sleep. Social connectedness we talked about, and encourage mind and body therapies, which I think the psychiatrist is going to talk about later on today. So this is a schedule of ideally how opioids should, the best way in which opioids should be administered. So there's a very narrow window in which opioids are able to work, the therapeutic window. If you're not average, if you're below that, the patient will have pain. If you're above that, the patient will have side effects. You should always note that there is really no ceiling to opioids. Patients can take as high as 100 milligrams per hourly of morphine. So there's really no ceiling to opioids. The trick is how quickly you get to that dose. So you should begin slowly and then work it up until the patient is well controlled. So this black circle here is what they call patient-controlled analgesia, where the patient feels the pain and takes their medication. So if the patient is the one who's controlling their analgesia, they're usually able to stay within that nice therapeutic window much better than if the health worker is giving the medication or someone else is giving the medication. Because, like they say, pain is what the patient says it is. So you cannot determine and say they're in pain or they're not in pain, like have you had problems with. The problem with that, of course, is a patient who has developed complex pain, in which case they will have other issues on top of the, like we said, on top of the physical, the psychological, and the social issues, such that they will get to a point where they get to addiction and abuse of the analgesic, morphine in particular. So if a patient has acute pain, the best thing to do is to carry out patient-controlled analgesia. The long-acting drugs are usually much better because, like we see this one, it stays a bit longer, so sustained-release drugs are better. The problem is knowing what dose is appropriate for the patient before you give them a sustained-release dose. And then what we have right now, the immediate release drugs, the 4-hourly dose. If the patient is outside if they're not giving themselves adequately, so it's supposed to be 4-hourly. If you're giving it 6-hourly or 8-hourly, then you won't have pain which is well controlled, and therefore you're likely to progress into complex pain from a patient who only had acute pain. So the routes of administration are also important. The oral drugs last a bit longer. Okay, so that's the black line. So it lasts a bit longer for patients. Therefore, you're within the therapeutic window much longer if you're taking oral drugs, compared to if you're taking the IV drugs or the subcutaneous drugs. So patients who comes in and they're in acute pain, severe pain, you want to get their pain controlled very, very quickly, then an IV drug is the best option for the patient. But once the patient is well controlled, then you will move on to the oral drugs, which give you much better pain control. So the non-pharmacological, when we go to management, really, the non-pharmacological management is the cornerstone for patients who have complex pain. Remember, we say things like cognitive behavior therapy, moving out of the cycle of dependency on oral medication, analgesia. That should ideally be the cornerstone of management. So once that has been instituted, then you can go on to the oral medication. So things like gabapentin, which are neuropathic agents, things like NSAIDs, things like antidepressants are alternatives to using morphine, especially for patients who have opioid-induced hyperalgesia. So the best thing really is to assess the pain and see where the pain is coming from. So the best things for peripheral sensitization are anti-inflammatory agents, like we talked about the NSAIDs. And then for central sensitization, things like gabapentin, things like pregabalin, that's the best. And you can combine them with antidepressants like amitriptyline. Then you can also look for what else the patient has on top of the pain. If the patient also is depressed, for example, then an antidepressant would be the drug of choice. If the patient, say, for example, is also really anxious, then pregabalin would be the drug of choice. So the key point is that acute pain should be managed immediately. If you wait to manage acute pain, it will progress into chronic pain, and that is a bit more complex to manage. The second thing is management is not just managing the physical pain of the patient, but also incorporating psychological and social aspects to the pain of the patient. Then a pain assessment for a patient who has sickle cell disease is very important to find out what is the cause, what is the trigger for the pain, and try to address the trigger as you manage the pain as well. Thank you.